Good morning and welcome to this YouTube channel, Painfree Partha. Today's topic is about segmental thoracic spinal anesthesia. So, I wish to place on record my sincere thanks to Dr. Bajwa and his team for giving me the opportunity to talk and discuss about this in a separate ISA sponsored session, webinar, which was well attended, and also my co-speakers were really experienced and in this type of segmental spinal anesthesia. Welcome you back again to YouTube channel Painfree Partha. Now, what is this segmental thoracic? What is this actually? Now, if this is spinal, if you are giving in the lumbar space, L1 is over, the spinal cord is over. Now we are giving in the lumbar system subarachnoid space. This is a normal spinous. Now, if you give where your spinal cord has not ended, this is where is the segmental spinal anesthesia. We are not giving here. We are giving in the thoracic spinal space. And we are not afraid whether the spinal cord is there or not there, taking appropriate precautions. This is what is called segmental thoracic spinal. It is administered normally what is there? L2, L3, L3, 4, 4, 5, L5. This is what is the normal spinal anesthesia. But we administer the drug in thoracic intraspinal space with idealized dosing to target the nociceptive site. Now your nociception is umbilical hernia, umbilicus, around T9, T10, T11. We put the spinal there in T9, T10 and then give the appropriate dosing, possibly 1 ml, 1.2 ml. This is what is called thoracic segmental spinal. So we will have an upper and lower levels. If we give 3 ml of bupivacaine in L3, L4 normally, only we see the upper level, T4, T6, because the lower level is completely blocked. But if we give thoracic spinal anesthesia, now what I want to say is, now this is umbilical hernia. We are putting 1 ml of bupivacaine in T9, T10, and it will block only from T7 to T12. That's all. So L1 is not blocked. So we will have a lower level and we will have an upper level in segmental thoracic spinal. There is no sacral or cervical. This is very important. We are normally lumbar spinal. There is no segmental thoracic cervical. There is no segmental sacral. So whatever we give segmental spinal, we mean that it is given in the thoracic segment. We are sparing the legs possibly. Now it is not just new. It starts from 1909. It was used to perform general spinal anesthesia, which would be performing segmental by using as close to possible to the innervation of the operative site. If your operation in this thing, puncture in T6, this was proposed by in 1909 by Jonesco. He performed the thoracic spinal in T2 for hidden upper limbs and puncture between T12 for lower abdomen. This is what he did in 1909. Still around 118 years gone, some 14 years gone. History continues, puts air and local anesthetic. In 1932, with a patient in lateral position and in Trendelenburg, a lumbar spinal puncture was attempted and CSF was removed and replaced by air, followed by hypobaric solution of Nupercaine was injected so that it will go to the thoracic. So these are all the history like to put the drug specifically in the thoracic spinal space. Nupercaine is nothing but dibucaine. So why we are afraid about this is we are afraid about the safety. Now there is one point must know areas. There is a greater depth of posterior subarachnoid space in the thoracic spinal cord. See here, in the thoracic spinal cord, the depth of the posterior subarachnoid space is more. So you have easy to inject, more space to inject. That is what is important. Is now 7.75 versus 5.88. So we have more space to inject here than here. So here you see the anatomy. We will go to this picture. Now you see spine. It is T3, T4 is more of angulation. Sometimes it is difficult to do, but here T1, T2 it is easier, and below T7 it is easier. But it can put in T4, T5 also, but it is difficult. This is T6 to T8, or some people call T5, T6, T7. Here, if you go to the subarachnoid space, is wider here. Posterior subarachnoid space is wider here than this is smaller here. That is what I want to tell as combating the first concern of thoracic segmental spinal anesthesia. Now here it is easy. If the spines are like this, may be difficult. And again it is easy. So T2, T3 is easy. Again T4 to T6, T7 is difficult. And from T8 onwards, it may be easy because the spine is like this. We may need to go like this. What are the indications of, now we know what is that segmental spinal. It is only available in thoracic. Now we know what is the history, how it went on. Now we know why we are giving posterior subarachnoid space is wider. Now we go to indications. Breast surgeries, cholecystectomies, colonic surgeries, even lap choles, gastrectomies, LSCS they have done, nephrectomy, hernia, appendicectomy, even laminectomies I have done, chest wall surgeries, and people have used even in children and infants. So thoracic spinal has got unlimited indications. Unlimited indications. The absolute contraindications, if you see, is again patient refusal, no consent, local infection, increased ICP, multiple sclerosis, sepsis, severe hypovolemia. What is striking in your mind? There is no difference between lumbar spinal contraindication and thoracic spinal contraindication. We can see there is no the same contraindication is also applicable to lumbar spinal, our routine spinal. The same contraindications are there for thoracic spinal also. Now, if you can say, is it safe to sedate a patient? Yes, I prefer to administer sedatives prior to the block. Midazolam 2 milligram with an opioid fentanyl. Sometimes we can also give 5 milligrams of ketamine prior and select cases and select diseases. Because sometimes we may need to give thoracic spinal in patients with multiple comorbidities and lung infections and morbidities. There we may need to select cases and diseases, then administer sedatives. Limit anesthesia to operative field and more diluted, smaller doses, undesirable drugs could be avoided. Most important thing is target the nociceptive site, give less volume. Duration is prolonged. If the surgical duration is prolonged, means we cannot give thoracic spinal. We have to combine the spinal epidural. Yes, we can give a thoracic spinal and also in the spine space put an epidural also. But this is the most important thing. Yes, it may not be useful for a prolonged surgery of more than 1.5 hours. What is the technique? Routine preparation doesn't change. Sometimes T5, T6, T7 may be difficult. T4, T5 or below T9 may be easy. Otherwise, we can use a para-needle. The needle we are comfortable with. It is nothing like that. We have to use 28 needle or 27 needle. I am fine with lumbar spinal 25. Use 25 in thoracic spinal also. I am fine with 26 in lumbar spinal. I am fine with 24 with lumbar spinal. Use that one. There is no concern about it. I need to give very small gauge needle which we may not have used in lumbar spinal and get into problems. Go slow. There may not be any clicks in thoracic spine. That is the most important trick. Tuck, tuck. The second click spinal, like lumbar, it may not happen. You may need to go slowly, remove this, and see whether there is a fluid coming. Go slow millimeter, again coming. There may not be this double click phenomenon and all. Maybe or may not be. Now, which is the space we have to identify? Use both sides because this is lower end of the scapula, lower end of the scapula, T7, spine of the scapula, T3. You can use both sides and this thing. Yes. We can use single shot segmental spinal. We can use thoracic epidural with segmental spinal. We can also use lumbar epidural with segmental spinal. Identifying the correct space seems central to a successful segmental spinal. You understood now? Spine of the scapula is T3. Use both sides. Inferior angle of the scapula is T7. Use both sides. But sometimes we may need to use ultrasound, or sometimes we may need to use fluoroscopy and see what is. Technically speaking, this is out, and ultrasound is coming slowly. People have used fluoroscopy of 1 ml La and 1 ml absolute alcohol in a cases of esophageal and gastric malignancies as palliation. Think of it. Put the patient in prone position and give 1 ml of local and 1 ml of absolute alcohol in T4, T5 for a case of esophageal malignancies. Now this is the normal dose. For example, breast surgeries, T1 to T7 it may be, T12 is not needed, 1.4 ml, 1.7 ml for gastrectomies, 1.2 ml and 2 ml for laparotomies. Caesarean delivery, you may need 1.4 ml. All these things are given in textbooks. We usually add 25 microgram of fentanyl. It has been found that approximately 1 ml of isobaric drug spreads about 3 segments above and below the site of injection. Now, if you give T9, 1 ml, now it spreads from T6 to T12. This is the basic idea. It should be borne in mind. 3 segments up, 3 segments down. If you give it T9, it is likely to block from T6 to T12. So that is what is to be put in the mind. So somebody may ask, what is the dose? Yes, where is the nociceptive site and where you are pricking? 1 ml blocks 3 segments above and 3 segments below. Now, what are the drugs used? Hypobaric bupivacaine, isobaric, hyperbaric, isobaric ropivacaine. All these drugs are routinely used with fentanyl, clonidine, dexmedetomidine, and midazolam, or sometimes in combination also we have used. So, isobaric bupivacaine, hyperbaric bupivacaine. Yes, I am coming to this point again. So, hyperbaric and isobaric both can be used depending upon what do you want. Isobaric or injected at the level of 5th thoracic can block simultaneously sensitive and motor. Hyperbaric means longer lasting sensory block than a motor block. Here you see, this is the dorsal nerve root, ganglia. This is the ventral. This is motor, this is sensory. Now you are dropping the local anesthetic and it is isobaric. Think hyperbaric or think whether it will come this side, whether it will go down, whether you are in prone position, whether you are given put the patient back in supine position, where will the isobaric or hypobaric go, whether it will go to the dorsal root. All these things we should be keeping in the mind by seeing this picture. We are giving prone or keeping back in supine. The local anesthetic we are giving is here, and your sensory neuron is here, and your motor neuron is here. So that is what we should give. This more towards ventral. Your motor horn is here. The amount of CSF in the cervical is 19. See here, thoracic is 38. Lumbosacral is 25 ml. So the latency of is practical, but you think that yes, I have given the drug in the thoracic spinal space, it has got 38 ml, so it may act slowly, it may act with less dose. All these things are not there. The action is immediate. Onset is immediate. Now, what are the complications you can see? Direct needle trauma, infections, abscess, meningitis, vertebral canal hematoma, spinal cord ischemia. All these things are almost non-existent, extremely rare. What are common is hypotension, nausea, vomiting, bradycardia, some mild paresthesia, transient mild hearing impairment, backache, retention. These you can see in normal spinal also. So that is why these things are uncommon and these are common, which is very similar to a lumbar spinal anesthesia. Now, what are the advantages? You can give morbid patient general anesthesia is doubtful, yes, potassium. If you want the legs to be spared and hemodynamic disturbance has to be less, yes. You want to have better pain control than general anesthesia, yes. You want to have better fast bowel recovery, yes. You don't want urinary retention, yes. You want some post-op analgesia, yes. Patient satisfaction, yes. Can be discharged earlier, yes. Less post-operative collapse, less post-operative atelectasis. Yes, if you have an airway like this and if you have a lungs like this, you can go for thoracic spinal in breast cases also. Absolutely, there is no problem. Put in T3, T4 level, give 1.2 or 1.4 ml of bupivacaine with 25 mg of fentanyl. You can operate breast within 1.5 hours. Yes, you don't bother about these things. See, people are worried about the relative contraindication is scoliosis. Here in scoliosis, we will prefer to give segmental spinal because there is a least interference in the respiratory system rather than GA. So already we know scoliosis will have restrictive lung disease. We don't want to alter. Put in 1.5 ml, put in 2 ml of bupivacaine in T9, T10 to do your whatever surgeries in the xiphoid process, epigastric hernia or all. You can avoid GA, yes, because in scoliosis, we know we should give least interference to the patient's respiratory system. There are all models to learn these procedures. You can use insulated Tugi needles, plasticine, thoracic spinal models, metal pipe connected to the ground floor, ground electrode, etc. We can use ultrasound to help us, posterior complex, lamina, epidural space, all these things. But I will go to the ultrasound in spinal in a completely different videos later. There are a lot of studies. It is not that simply here and there studies. Lab poly under segmental thoracic spinal. It is in British Journal of Anesthesia long back, 2007 or something. So many studies. In this small study, you have done 20 healthy patients. Side effects were minimal. Satisfaction were excellent. Cardiovascular changes might be greater in old patients and those with incurrent disease. Everything is okay for a feasibility study of 20 healthy patients. Segmental spinal for cholecystectomy. Again, British Journal of Anesthesia, 47 years. Is actually posted for lung transplant. See here, the patient is posted for lung transplant. Now what they are doing is, patient has got an incident at cholecystitis. So T10 space 1 ml of bupivacaine with supantanil they have given and done the lab chole in this patient who is going for lung transplant in 1 or 2 months. Efficacy in laparoscopic cholecystectomy. So many studies have been done, and Palibal has given so many studies and publications. T7 to T10, anything is feasible. 1.5 ml of isobaric ropivacaine with 5 mg of dexmet. 30 milligram of ketamine is used on these patients. Yes, this is what they have done. T8, give 1.5 ml of isobaric ropivacaine with 5 mg. They have done laparoscopic cholecystectomy in many cases. Now, what are the concerns? No, I'm not going to give. I'm 40 years of experience in lumbar and all these things. What is your concern? Number one, neurological injury. There is nothing like that. They have proved, MRI has proved, posterior subarachnoid spaces is wider, angulated entry, safety is established. So you don't need to worry about all these things. Concern is, yes, sometimes we get even paresthesia when we go into the lumbar space. What do we do? Same thing, the root can hit affected. All these things are not impossible. But concern number one, neurological injury about going ahead, above is gone because your posterior subarachnoid space is wider and an angulated entry. Now we will go to concern number two. High thoracic blockade could block intercostal nerves, which innervate the intercostal muscles that assist breathing. Yes, we may not breathe well. I cannot breathe. All these things the patient may tell. But the concern is gone because the diaphragm, which is a key muscle, is spared as it derives its complete motor supply from C3, C4, C5 segments. Now, if you give T4 1 ml, it is going to block from T1 to T8, 3 segments up, 3 segments down. We are not going at all near C3, C4, C5. Yes, this concern is completely gone. So the patient will have normal diaphragmatic function. What is the concern number 3? The cardio accelerator. Yes, high neurax. We are giving in T4. So T1, T2, T3 is blocked. Now we are, yes, T6 completely gone. So vagus will predominate and this will produce refractory bradycardia. This is our concern. But this doesn't happen because your inverse vein bridge reflex is fine. Vein bridge reflex is fine. We don't have pooling of blood in the legs. Yes, the leg is not paralyzed. So this is pooling, though tachycardia remains. This will counter. So this concern of intense bradycardia by producing the cardio accelerator nerves is gone because there is no pooling. Blood flows into the right atrium. The stretch is fine. Tachycardia is there. So it comprises the so-called vagal concerns. Vaginal hysterectomy, I feel it is difficult to do. Abdominal hysterectomy we can do, lap abdominal we can do. Either sometimes we may need to do a sacral block separately. That is the most important problem. Sometimes the S2, S3 may be spared. So this is questionable, but people have done. Segmental spinal is all about lower lumbar and sacral sparing. So that is how the BP doesn't fall much. Trendelenburg for appendicectomy and reverse Trendelenburg for cholecystectomy are not problems if we do it after 5 minutes. Yes, we have given in T4. If you give Trendelenburg, or this will go and nothing like that. If we give after 5 minutes, your Trendelenburg or something, yes, everything is because we have given only 1 ml. That is what is important. We have given only 1 ml. It is not 1 ml is not going to above C5 or something like that. So hardly 0.05 ml may go strict to go to C8 or something, which is not going to be anything clinically significant. So that is the important thing because we are targeting the nociceptive site and giving less doses of local anesthetics, which is the main advantage, so that there is no problem with Trendelenburg or reverse Trendelenburg. 2 cases of thoracic in patients with severe disease. 1.4 ml of isobaric bupivacaine with fentanyl. BP of 180 systolic. Skin lesions in the lower back. Full stomach. Yes. Severe preeclampsia. Now this is in somewhere in 2000. Thoracic spinal anesthesia for cesarean sections. Now what I have given is a lap cholecystectomy. My case, I have given around T9, T10 space, 2 ml of hyperbaric bupivacaine with 25 mg of fentanyl. This patient is only on oxygen and lap chole is going on. This is another case. Now you see the back. This is my case one. You can see Parthasarathy et al. Published. This is the big lipoma. This is the scapula. And scapula, it is bigger lipoma is there. And I'm just giving spinal here. 1.4 ml of bupivacaine with fentanyl in T4, T5 interspace, and the level was, I think, from C8, some C8 to T7. So we got it finished easily. Absolutely, there was no problem. And BP fell down, and we gave 6 milligrams of ephedrine. There was no bradycardia. Yes, everything went on fine. So what is this? This is giving the spinal drug in the thoracic segment. There is an upper level and lower level. There are a lot of indications from breast, gastrectomy, epigastric hernias, common hernias, appendicectomy, lap chole, lap appendix, lap hysterectomies, even laminectomies, so many things, even in children, adults. What are the contraindications? It doesn't change from the normal spine. What are the technique? The most important is the technique. We will not give so many gives. We should go in slowly and get it. The needle, you may not change 25, 24, 25, 26, anything which I am used to do, which you are used to do that. Drug spread and dose. We always add fentanyl But some people add Dexmed to prolong the duration, 5 mics of Dexmed. Give 3 ml, target the nociception, target your injection. 3 segments up, 3 segments down for 1 ml. If you are thinking in terms of supine, think about your hypobaricity or isobaricity. What is the effect you want, sensory or motor? Advantages over GA is so many. Airway problem is not there. Lung morbidity is okay. Everything is okay. Concerns and answers. Concern 1, 2, 3, we have answered. Thank you very much. And you can go to my website www.painfreepartha.com to download my slides free of cost, edit and you can change. And my website and my YouTube channel is Painfree Partha. Subscribe, enjoy, listen. Thank you very much.